Thank you for your kind introduction, Tamar, and thank you, David, for the seamless handover of the chain. On each node of the chain are inscribed the names of former presidents, and it is a huge honour to follow these leaders in tropical medicine. And I want to thank all of you for the many messages I've received from around the world since becoming president-elect. I'm very much looking forward to serving as Royal Society of Tropical Medicine and Hygiene President. And so I hope this address will help you learn a little bit more about me and will introduce the Royal Society of Tropical Medicine and Hygiene to those of you who are relatively new members. Those of you who know me and now see my title slide will guess that I'm going to talk about the condition that has become my career, my vocation, and my obsession, podoconiosis. You won't be disappointed. I am going to talk about podoconiosis. But first, I'm compelled to talk about something even more important to me, my research group and medical school, and to the Royal Society of Tropical Medicine and Hygiene. This year, in particular, it seems impossible to discuss anything of relevance to global health, whether it's COVID, the WHO NTD Master Plan, or yes, podoconiosis, without first acknowledging the Black Lives Matter movement and all that this must mean for organisations and societies such as ours with a history linked to colonialism. I realise this may be an uncomfortable and painful discussion, but it is essential that RSTMH has it. So, in the first section of this address, I will put forward my reflections on RSTMH's past and future. I'll sketch its origins in the British Colonial Office, touch on debates around the tropical medicine that is part of the Society's name, and outline the progress made by the board and our executive team to establish a way forward that is more inclusive of Black and minority ethnic voices. I should say here that I'm no political scientist or historian of colonialism, and would like to acknowledge right away the ongoing work of several institutions on decolonising global health, including that of the London School of Hygiene and Tropical Medicine's Centre for History and Public Health. This is particularly relevant given the extent of connectedness between the origins of the Royal Society of Tropical Medicine and Hygiene and the London School of Hygiene and Tropical Medicine. So, The Lancet reported the foundation of the Society of Tropical Medicine and Hygiene on January the 4th, 1907, at a meeting held in the Colonial Office. And note, the Society would only become royal in 1920. As former RSTMH President Gordon Cook reported in his 1993 presidential address, the Society's aims were described as specially directed to the stimulation of inquiry and research into the causes, treatment, and prevention of human and animal diseases in warm climates by promoting social intercourse between scientific workers in all parts of the tropical world. The formation of the Society mirrored that of the London School of Tropical Medicine, founded in 1899 by Patrick Manson, then Chief Medical Officer to the Colonial Office, and Joseph Chamberlain, then Colonial Secretary. Chamberlain's constructive imperialism channeled Manson's expertise and ambition in this new project. At the opening of the London School of Tropical Medicine, Manson outlined his aims for the school and its graduates. He said, "The school strikes and strikes effectively at the root of the principal difficulty of most of our colonies, disease. It will cheapen government and make it more efficient. It will encourage and cheapen commercial enterprise. It will conciliate and foster the native." The first cohort of physicians to graduate was told that it shall not only leave its mark in the history of tropical medicine, but shall also exercise an influence for the good in the development of the empire. Based on these quotes, and objectives, it seems hard to deny that the origins of both of the London School and the Society were steeped in the imperialism of the time. The aim of tropical medicine at the turn of the 19th century was firmly about supporting the expansion of European colonial powers. But of course, you may say, along with Bruce Fetter, does bad colonial conduct in the economic sphere necessarily exclude good intentions towards African health? Of course, it doesn't exclude them. However, if the ultimate aim of tropical medicine was to enable the exertion of expert control over colonial empires, then these good intentions were vulnerable to stronger pressures and to slipping into neglect. The Royal Society of Tropical Medicine and Hygiene has debated the role and future of tropical medicine at many points in its history, and you'll be relieved to hear I don't plan to revisit all these debates now. However, I will turn to a debate held in 1996, because during this, a potential way forward for tropical medicine was recognised. Gordon Cook had proposed the motion, tropical medicine is dead and should be buried. And in his opposing argument, Tony Bryson explains why he doesn't believe this to be the case. He says, tropical medicine is a specialty that cuts across the fragmentation of medicine into ologies, and that is a good thing. It describes the background, the backcloth against which the ologies are practiced. Without this backcloth, the ologies lose their way and public health measures don't work. This sense of the backcloth is, I believe, vital. Others on the floor, including Anthony Costello and Andrew Tompkins, began to clarify what this backcloth might comprise. And I think here we start to see that tropical medicine is enacted against a backcloth that includes, for example, racism, structural adjustment, and gender power imbalances, all of which provide the context for diseases of poverty to flourish. This backcloth represents what is now known as structural violence. Broadly, structural violence is a scenario in which a social structure perpetuates inequity, thus causing preventable suffering. It's not enough simply to describe it. Members of societies like the Royal Society of Tropical Medicine and Hygiene must directly contribute to dismantling these structures internally within the society and in the work in which we are engaged. Having now exposed the problem, let me turn to some ways in which each of us as individuals and RSTMH more collectively may correct institutional structures that perpetuate inequity. And again, those of you who know me won't be surprised that I'm going to use an example from athletics to do this. At the 1968 Olympic Games in Mexico City, Americans Tommy Smith and John Carlos, the gold and bronze medal winners in the 200 meters respectively, each bowed their heads and raised a black-gloved fist while on the podium during the playing of the US national anthem. While both men were vilified at the time and for decades after, their action has become one of the most iconic moments of Black protest, and both men understand the profound effect it has had on subsequent movements, including Colin Kaepernick's NFL protests and the current Black Lives Matter movement. As Smith said, we had to be seen because we couldn't be heard. Now, given the predominantly white European membership of RSTMH, let's also look at the third man on the podium. Australian Peter Norman took a surprise silver medal in this race. Aware that Smith and Carlos were planning a salute, but only had a single pair of gloves between them, he decided to signal his support by wearing an identical Olympic Project for Human Rights badge to those that they were wearing. Like Smith and Carlos, he paid a heavy price for his solidarity in his homeland, but the importance of his support was lost to none of them. Norman later said, "I ended up running the fastest race of my life to become part of something that transcended the games." So, while many of us may not know how to support our Black and minority colleagues through this incredibly turbulent time, publicly indicating this support is an important start. Even a badge can become a powerful, transcendent symbol of solidarity. But as individuals working in tropical medicine, we need to go beyond the badge. Each of us needs to face up to the painful legacy of tropical medicine and ultimately reach a point of unconscious unbias, where it is understood that the fight against tropical diseases benefits us all. At this point, tropical medicine will no longer be seen through a certain lens because of the parts of the world in which tropical diseases are most prevalent. Each of us in this eminent and historic society must recognise the power, privilege and resources we have and commit ourselves to scrutinising their use. Each of us needs to stand up for others and ourselves when we see or hear prejudice. And beyond individual members taking stands, how might RSTMH demonstrate commitment to equity and against discrimination of all kinds, including race? So first, I want to congratulate Tamar and her team and the current board for numerous positive steps already taken. For example, the expansion of the research in progress events beyond the UK and the introduction of student and country ambassadors. I'd like to add my heartfelt welcome to all these and show you the first 12 RSTMH country ambassadors. Future plans, as you'll have been aware from our annual general meeting, include the creation of 2 additional appointed places on the board to bring expert regional voices to the centre of RSTMH decision making. So I signal here my full support to the board and executive team as these vital changes come into place. They will make RSTMH better equipped to address the backcloth against which tropical medicine is done. And so, prompted by RSTMH creating appointed places for regional experts on its board, I'll move to the second part of this address. The link here are Obadiah Johnson and John Randall. These were the first Africans to be permanently appointed as assistant colonial surgeons in Nigeria. These overdue appointments were made in 1889, a full 28 years after the founding of the Old Colonial Hospital in Lagos. The reason for the appointments? The removal of 2 European doctors following a scandal around the death of a patient named Adiola. This elderly lady had been forcibly discharged from the hospital and deposited in the bush opposite before being readmitted and dying a week later. What was this callously treated woman's diagnosis? It was incurable elephantiasis. So then, I will move on now to an overview of the past 15 years' research into podoconiosis, the lesser-known form of tropical lymphedema, and formerly known as non-filarial elephantiasis. I will celebrate the successes of an approach underpinned by local research capacity building. It is only through my colleagues in Ethiopia, Rwanda, Cameroon, and other endemic countries that this research has so rapidly had translational impact on policy and ultimately patient care. I was first introduced to patients with podoconiosis in 2002 by Meskele Ashin, director then of the Mossifoot Treatment and Prevention Association in southern Ethiopia. As well as being a gifted implementer, Meskele was a visionary looking well beyond his own patch and understanding the role that research could play in bringing visibility to this completely neglected condition. Mescali understood the value of linking his NGO with the Masters in Public Health students at Addis Ababa University, so that Ethiopian expertise in this condition could be fostered. Under his guidance, a household-based survey among 33,000 residents of Wolaita Zone documented an astonishing podoconiosis prevalence of 5.5% in the general population. This was the start of a programme of research which built on Ernest Price's earlier work through the 1970s and 80s. Since 2003, the programme has deployed a wide range of disciplines to understand the etiology, distribution, prevention and treatment of podoconiosis. These disciplines have included epidemiology and public health, clinical medicine, genetics, histopathology, microbiology, ophthalmology, mental health, ethics, sociology, behavioural science, economics, health systems research, diagnostics, geology, and mineralogy. Let me talk you through just a few of these now. 2 Masters in Public Health students first worked with the NGO in southern Ethiopia to study the economic and social burdens attributable to podoconiosis. One of them, Fasil Tekola Ayla, continued to a PhD on the genetic epidemiology of podoconiosis at Brighton and Sussex Medical School, conducting the first genome-wide association study on a non-communicable disease in Africa, and demonstrating a convincing association between podoconiosis and single nucleotide polymorphisms in the HLA class II locus, giving him a New England Journal first author paper. The right-hand picture shows him presenting a copy of his thesis to Mescali. Now, under Melanie Newport's leadership, one of 7 work packages within the NIHR-funded Global Health Research Unit for NTDs at Brighton and Sussex Medical School is exploring downstream immunopathogenic consequences. Podoconiosis is fascinating. It seems to be a condition with genetic, environmental, and behavioural antecedents. A combined geology epidemiology approach has attempted to understand what it is in the soil that triggers podoconiosis once inside the lower limb tissues. Following combined epidemiological and geological fieldwork in northern Ethiopia, disease prevalence data were modelled against an analysis of soil sampled from the same locations. This approach suggests that phyllosilicate materials like smectite clays and mica, quartz, iron oxide, and zirconium may be associated with podoconiosis prevalence. Similar analysis of soil samples from Cameroon is being conducted in collaboration with the universities of Buea and Brighton. Another important strand of work that developed in parallel to the above studies is that of using rapid ethical appraisal prior to the more sensitive research. Rapid ethical appraisal is a brief qualitative intervention designed to map the ethical terrain of the research setting prior to a research team recruiting participants. It arose as researchers identified a gap between universal ethical values and local realities, and was initially developed and tested by Susie Bull and Bobby Farsidis in the Gambia. When preparing for the first genetics investigations in Ethiopia, we realised the difficulties of obtaining genuinely informed consent from already vulnerable communities with low levels of exposure to Western science and research. We have used rapid ethical appraisal prior to each genetic study in Ethiopia and Cameroon, and before the treatment trial that I will describe a little later. Rapid ethical appraisal has been enormously valuable in understanding how communities prefer to be approached, how to convey information about a specific study by, for example, using agricultural analogies, how to elicit consent, and how to maintain retention in follow-up studies. Adamu Adisi's series of PhD studies using rapid ethical appraisal led to its inclusion as an approach in the Ethiopian National Ethics Guidelines. So alongside the biogeomedical studies and in addition to the ethical appraisal, there's been an important stream of social, anthropological and behavioural research led by Getnet Tadler. This has explored individual and community perceptions of disease, hereditary and shoe wearing, health-seeking behaviours, stigma and barriers to care. Social, economic, psychological and mental health consequences of podoconiosis have been documented, and a household-based behavioural intervention to optimise use of shoes by children was trialled. Earlier this year, we launched the NIHR-funded Social Sciences for Severe Stigmatising Skin Conditions Foundation, which is called 5S for short. This will enable this stream of research to be expanded to cover 2 other skin NTDs, scabies and mycetoma, and to build research capacity in the social sciences in 2 further countries, Rwanda and Sudan. And then there is the remarkable programme of mapping led by Kebede Deribe, also known to many of you within the Royal Society of Tropical Medicine and Hygiene as a country ambassador and an emerging leader awardee. Nationwide mapping of podoconiosis conducted by Kebede for his PhD enabled him to supply critical data inputs to the first Ethiopian NTD master plan. He now leads the Wellcome-funded Global Atlas of Podoconiosis project, supporting mapping in Cameroon, Rwanda and Kenya to date, with preparatory work ongoing in Uganda, Burundi and India. Providing robust evidence to guide control and elimination programmes is core to our work within the Centre for Global Health Research at Brighton and Sussex Medical School. Testing a standardised package of care comprising foot hygiene, compression, exercises and elevation and use of shoes and socks was carried out through a pragmatic randomised controlled trial which was called Golbet in northern Ethiopia in 2014 to 16. This trial, led by Mesret Molla and Henok Negusi, enrolled 696 participants and demonstrated a clear reduction in frequency of acute attacks. These are the most debilitating consequences of podoconiosis, and improved quality of life. It was also found to be most cost-effective amongst the poorest patients. There are many other studies that I've not been able to talk about, so do look out for many more in the upcoming special issues of the Transactions of the Royal Society of Tropical Medicine and Hygiene. We're hoping this will come out later this year. And finally, I'd like to mention the people and organisations who've enabled this research to get to those who need it most: the patients, the implementers, and the policymakers. I will mention 4 here: Sige Amberbe, Buruk Kebede, Asrat Mengiste, and Fikre Haile Geros, the founding and subsequent directors of the Ethiopian National Podoconiosis Action Network. Each has been sufficiently involved in the research to convincingly convey it to the key audiences, whether groups of patients, health professionals in training, or civil servants within the Ministry of Health. So I want to thank them enormously for the part they play. Now, as I approach this year as Royal Society of Tropical Medicine and Hygiene President, I hope to bring the same principles of equity and partnership to the role as I have through my research career. In particular, I will support the board and executive as they go beyond the badge against discrimination of all kinds. So many thanks for listening, and I look forward to your questions.